Well, it's really a pleasure to be with you. I think that this talk is going to complement what you just heard. And so I'll be covering advances in adjuvant radiotherapy. And 2023 was actually a banner year in terms of advances in personalizing radiation therapy and in terms of the synthesis of many trials. And so I'm going to break this into three subtopics. I'm going to talk first about what we know about regional nodal irradiation. And this, of course, applies to post-mastectomy radiation as well as irradiation of the regional nodal basins after breast conserving surgery, because there were two really big advances in 2023. There was, for the first time, a focused early breast cancer trials collaborative group meta-analysis that was published using individual patient level data that was really quite informative. And we saw the abstract presentation at San Antonio of the long-awaited NSABP B51 RTOG 1304 trial that was looking at what happens in patients who have pathologic complete response after neoadjuvant chemotherapy in their nodes about the radiation therapy implications. You heard about the surgical implications just now. So there was also a landmark Astro consensus guideline update for partial breast irradiation that I want to talk about for a bit. And then I'll close with a brief mention of several studies that came out about radiation therapy omission after breast conserving surgery, trying to increase the group of patients to whom we can offer more options, as well as to contextualize the results of the long-term Prime 2 results and Lumina and IDEA and also Prospect, all of which were published in 2023. So many studies along those lines. So before we dive into those three subtopics, I just want us to think a little bit upfront about the rationale for radiation treatment in the first place, right? So there's two things we're trying to do here. One is to prevent local regional recurrence, which, as we know, can be very morbid, particularly after mastectomy or in the regional nodal basins. It can be very difficult to salvage. And also, even if it's in the breast itself, no patient with cancer will tell you that it's not a big deal to have an in-breast tumor recurrence. These are things that come with considerable psychological trauma, as well as the need for additional surgery, additional treatment. So this is not something we should take lightly, the local regional recurrence reductions that are afforded by radiation therapy. And as you'll see over the course of my talk, I'm talking about de-escalation, but I don't want us to lose focus on the fact that the relative risk reductions with radiation treatment you're going to see are 2/3 or greater. So really, the only people in whom we're considering de-escalation or optimization of treatment by removing radiation treatment are patients who have very, very low absolute risks. We're cutting that risk by, by 2/3, cutting it down to 1/3 of that risk doesn't seem like it's something that the patient wants to pursue radiation treatment for. And there have been many advances in radiation treatment that I'll mention over the course of this talk that have made radiation treatment much more efficient and much more tolerable. So it's becoming a much more nuanced decision. I get to have lots of conversations with patients where I have the happy opportunity to say, this feels like a really big stakes decision, right? And it's a very difficult decision because the balance is pretty close here. But the good news is that you're overwhelmingly likely to do well in terms of disease control and overwhelmingly likely to do well in terms of toxicity and burden, whether you choose to omit radiation treatment or whether you choose to have it, which is a really nice place to be in these days for many patients. Of course, not for all of our patients, and we do need to do a better job of detecting and treating patients with conditions like inflammatory breast cancer. The prior speaker noted that those patients are often excluded from many of our randomized trials, and I will promise I'll get off my soapbox in a second, but IBC really is something that we need to do a better job of. The other purpose of radiation treatment, though, is to prevent seeding and reseeding of distant metastases from a persistent, isolated reservoir of local disease. And so it's that second mechanism by which radiation treatment influences survival. And there is a very important theoretical perspective on how radiation treatment and all treatments that affect local control may affect survival related to the effectiveness of systemic therapy. And as you can see here, in the era when we had very few effective systemic therapies and we were really constrained by the microscopic disease that might have already reached other sites, local therapy does not have much impact on survival. It's only when we have reasonably effective systemic therapies that we see the maximal impact of local therapy on survival, because that is the time that then that isolated local regional reservoir might actually serve as the only source of distant metastases, because the smaller volume disease that has gone elsewhere already has been addressed by other treatments. Of course, if we ever end up with the silver bullet of systemic therapy that kills every last cancer cell in the body, you won't need either us or the surgeons, but sadly, we have not reached that day yet. And so I will begin by focusing on regional nodal irradiation, which is, of course, an area where both local control and overall disease control are extremely important. There has been for a long time, as we all know, a controversy about what to do with patients with N1 disease, 1 to 3 positive lymph nodes. And the landmark trials of post-mastectomy radiation therapy that came from Denmark and Canada in the early 1980s, published in the late 1990s, did include N1 patients and did suggest benefit from post-mastectomy radiation treatment that included treatment of the regional nodal basin, specifically the supraclavicular, the infraclavicular, the axillary, and the internal mammary nodal regions. But there were concerns about generalizability of those historical trials due to things like inadequate axillary surgery, right? Everybody remembers that the Danish trials had a median of 7 lymph nodes removed. And of course, no good American surgeon was removing 7 lymph nodes on an axillary lymph node dissection back then. But we have to consider the impact of many changes over time that have occurred since 1982, when those Denmark studies were initiated, that have caused the absolute rates of recurrence to fall in ways that may reduce the importance of regional nodal irradiation. And that goes all the way from advances in radiology and imaging that lead to better screen detection of cancers, surgical and pathologic advances that are leading to clearance of margins and detection of small amounts of axillary disease, much, much smaller numbers of cells, right? You were talking about isolated tumor cells in the last talk, and micrometastases, and what do we do in those cases? Sentinel lymph node biopsy is detecting very, very small amounts of nodal involvement, and the implications of this, those micrometastases and those isolated tumor cells in particular, would have been coded as node negative and would not have been enrolled in these historical trials. There are better systemic therapies, of course, as we all know, including targeted therapies and longer durations of endocrine therapy. And we also have to recognize advances in radiation treatment delivery that have reduced toxicity in ways that might increase the net benefit of regional nodal irradiation by reducing the harms, the mortality harms of regional nodal irradiation, for example, damage to the heart or lungs. So I told you there was a new EBCTCG meta-analysis published in the fall, and it included 17 quote, randomized trials that started before 2009 and had been conducted worldwide. The only difference in these trials between the two treatment groups was the irradiation of regional lymph nodes in 1 or more of the 3 regional nodal sites, IMNs, supraclav, axilla. Now, I do the quotation mark thing because one of these 17 was actually not a randomized trial. It was the Danish study where the national policy towards treatment was that laterality determined regional nodal irradiation practice. So if you had right-sided disease, you got internal mammary nodal irradiation. If you had left-sided treatment, you did not. And the statisticians in Oxford felt very comfortable that this was pseudo-randomization and chose to include this in the primary analyses. But as you know, with EBCTCG meta-analyses, there are always really bulky web appendices. So if you want to see what happens if you exclude that one trial, you can see that that one trial doesn't drive anything in the results. It's important to recognize that these were unconfounded comparisons, so any surgery and systemic therapy was the same for both study arms. And the EBCTCG got individual patient data from all but one of those 17 trials. So that led to the omission of 165 patients, but really quite impressive work here. And so there were 8 older trials and 8 newer trials, conveniently enough, and they were different. Okay, so the 8 older trials, the radiation treatment was anterior photon beams, and usually the patients were not receiving chest wall radiation. So the comparison really was regional nodal irradiation versus no radiation. And only 1.6% of these patients received breast conserving surgery. So these are the vast majority of these patients are receiving mastectomy, and very few of them are receiving systemic therapy. Okay. In the newer trials, where the radiation technique was more tailored to spare the heart and lung, the patients typically did receive treatment with radiation to the breast or chest wall. So the comparison here was more radiation treatment, including the regional nodes, versus less radiation treatment, just treating the chest wall or breast. And the majority of these patients actually received breast conservation, chemotherapy, and endocrine therapy. And you can see here the distribution of what happened on these older and newer trials. And you can see, and I'm going to come back to this at the end to reflect on the internal mammary nodal region, that 4 of the 8 more recent trials, which are the ones that we're going to obviously focus on because they use more modern techniques, 4 of those actually focused on the IMN specifically, and 2 others actually included the IMNs in their randomization. So the majority of these newer trials did include IMN radiation as part of their question. And you can see here again the differences that I mentioned in terms of the treatment planning techniques. And again, these are more modern style radiation therapy. So in those 8 newer trials, which started from 1989 to 2008, regional nodal radiation significantly reduced recurrence, with a main effect being on distant recurrences. Relatively few regional nodal recurrences were reported. And that may be, as you know, because we tend not to screen for recurrences in the internal mammary nodal region. So in particular, this suggests when you see an impact on distant recurrence and not on regional nodal recurrence, we do pick them up when they're in the supraclav or the axilla. We don't tend to pick them up as well because we're not screening for them in the internal mammary nodal region. And so if that isolated reservoir of disease ends up being a source for distant metastases and the patient presents with distant metastases, you can understand how eradicating that reservoir of disease might lead to an improvement in distant recurrence, even though radiation is a local regional treatment. And of course, regional nodal radiation also significantly reduced breast cancer mortality with no effect on non-breast cancer mortality. And regional nodal radiation in the older trials had a very different pattern with little effect on breast cancer mortality, but a significant increase in non-breast cancer mortality. So that's the contrast. For those of you who like to see things in pictures rather than words, this is exactly what I just described in the newer trials. You can see that reduction in any first recurrence. Again, the significant reduction in mortality on the top right, no difference in non-breast cancer mortality on the lower left, and you can see here any death on the lower right. Now, they did some heterogeneity testing and found that the proportional reductions in recurrence and breast cancer mortality actually didn't vary significantly according to most tumor or patient characteristics or treatment characteristics. But they did find that the proportional effects of regional nodal irradiation were greater for women with medial or central tumors, which is really interesting. And again, for those who like to see it in a visual depiction, you can see here that there's no interactions going on for most of these characteristics, but there does appear to be something going on here with the location of the tumor. I'm sorry, and I'm having a little bit of trouble with where your pictures are going here. Okay, and absolute benefits here are incredibly important to patients. Remember, it's not relative risk reductions that patients care about. They care about those absolute benefits. And so you can see here that the gain from regional nodal radiotherapy in these N1 patients is close to 3%, both in terms of any recurrence and in terms of breast cancer mortality. So do we need to include the internal mammary nodal region? This has been another hot button topic. I think my very first paper I ever wrote in breast cancer was about whether we include the internal mammary nodal region, and it was inspired by the fact that back when I was in training in the early 2000s, we saw that almost everyone in France radiated the internal mammary nodal region, and almost no one in England did. And I was training in Boston at the time, and we found the exact same split in practice patterns between the Brigham and Women's Hospital, Dana-Farber, versus the Mass General. So you could see that there was controversy because there was just complete polarized split in practice pattern. So we finally now have evidence to guide us. It's important to recognize that advances in radiation treatment techniques have been really transformative, and there was no increase in non-breast cancer mortality in the newer trials. And really, the big concern about treating the internal mammary nodal region is whether we can safely do that in terms of dose to heart and lungs. Most of those newer trials did include internal mammary nodal radiation, which suggests that with modern techniques, we actually can do a good job of sparing heart and lungs. And of course, there are dosimetric studies that have shown we can achieve very low doses with modern treatment planning techniques. It's especially important that, as I showed you, that proportional benefit of regional nodal radiation was greater for the people who had medial or central tumors, because again, it supports that hypothesis that it might be the internal mammary nodal radiation component that's effective at reducing recurrences from medial or central cancers. And again, as I mentioned, that the main effect of regional nodal radiation was on distant recurrence rather than local regional recurrence, because again, those IMN recurrences aren't as readily detected. It's important, again, also to note that the most common comparison here was specifically comparing IMN versus no IMN. So we do have gathering evidence here, even before the EBCTCG meta-analysis was published. There were some visionary editorialists who deemed the case to be closed, and they make some very good points, which is that internal mammary nodal irradiation was included as part of the regional nodal irradiation in the major historical trials that established that there were improvements in cancer control with post-mastectomy radiation therapy and regional nodal irradiation. And so what we really need is evidence that omitting it isn't compromising cancer control outcomes, rather than trying to design studies that prove that IMN irradiation is superior to no IMN irradiation. And individual trials, like the Korean trial, were enormously underpowered to detect what they were looking for, which was a 10% absolute improvement in 7-year disease-free survival. So, what actually improves any cancer control outcome by 10%, right? Many systemic therapy interventions get approved based on absolute values of improvement of only 2 to 3%. So, when we're talking to patients about whether we should include the internal mammary nodal region, when we think about those N1 patients, and I showed you the absolute benefit being close to 3%. And for many patients now who are getting breast conserving surgery, it's not even an issue of more visits for radiation. They're coming in anyway. It's a little bit more work for us. Okay, it's a lot more work for us. We should be doing that work. It's this is a situation where if we can have a modest improvement in disease control and not increase non-breast cancer mortality, we should be trying to achieve that. And this is just showing you how modern radiation treatment does spare the dose to the heart. And you can see that there are many ways to achieve this with modern treatment planning techniques to really scoop around the heart, and in particular, that left anterior descending coronary artery that lies right there anteriorly. And, taking a deep breath in is one of the best ways to do that. So in addition to all these fancy planning techniques, having the patient take a deep breath in just shifts that anterior edge of the heart further back. And no, just in case you're wondering, it doesn't introduce more lung into the treatment field. It's only inflating that sliver of lung that's in front of the heart to begin with. So the lung tissue is actually getting pushed out of the way too. So this is a very important technique, and one that as yet has not equitably diffused clinical practice. There was a recent study by a colleague of mine, Christina Chapman, who published in JNCI that our patients in the state of Michigan were receiving higher heart doses. And when we looked, a lot of that was driven by access to breath hold. So if you don't have breath hold devices, this is something to really, really emphasize as incredibly important for patients. Up to here, I've been telling you, I kind of think regional nodal radiation is a good thing, but like any treatment, it does have some toxicity. So we do need to consider ways to optimize and de-escalate treatment. And so there are subgroups of patients here. Anytime there's a benefit of treatment, we can always try to identify the lower risk population of patients in whom that treatment is not necessary. And the NCIC 39 is an ongoing trial that is very important considering advances in the understanding of tumor biology. And NSABP B511304 was looking at whether we could use nodal pathologic complete response to help guide our regional nodal irradiation treatment. And so, there is an increase. You can see here increased rates of dermatitis, increased rates of pneumonitis, increased rates of lymphedema that are associated with regional nodal radiation. So I told you there's not the serious cardiac mortality downsides, but there are some acute and some delayed consequences that are meaningful to patients. And you can see these here from the EORTC trial, the 22922. Again, a signal that we should be trying to be selective in reserving these treatments. And so digging deeper into tumor biology is incredibly important to guide us. There are trials that suggest, I'm so sorry, this is the thing about Zoom things, right? I have no idea how to make that phone stop ringing. There are trials that suggest that there's a benefit from regional nodal irradiation in node-positive breast cancer patients, but the absolute benefit is, of course, not uniform. And sorry. Okay. And so in Responder, which you'll remember is the SWOG 1007 trial, where patients with hormone receptor positive, HER2 negative breast cancer and 21 gene recurrence score results less than or equal to 25 were randomized to endocrine therapy alone versus chemotherapy and then endocrine therapy. And so, of course, the primary question was a systemic therapy decision-making question, but it was actually a really great source of information about modern regional nodal radiation practice patterns and rates of local regional recurrence in such patients. And when we looked, what we found was that the cumulative incidence of local regional recurrence between 1 and 5 years was extremely low. Okay, this is blown up, so you can see that the scale goes up to 5%. Okay, so I had to do that to show you the different groups here that you'd be interested in. But this is the main takeaway here is that these risks are very, very low out to 5 years. But of course, the benefits of regional nodal irradiation may be late, so we need a randomized trial to look at whether patients with favorable biology, like those enrolled in S1007, might safely avoid radiation treatment. There was a noteworthy split in practice patterns that suggested true clinical equipoise. About half the patients got radiation treatment to the regional nodes, and about half of them didn't in this trial. And so we concluded that we strongly encouraged accrual to NCIC MA39, which is ongoing. And I just wanted to emphasize to you that there have been relatively recent edits to this trial in an amendment that now broaden eligibility criteria. It's a very large trial. You can see here a couple thousand patients that we need to accrue. It's a very easy randomization. The patients who get who get breast conserving surgery are getting radiation to their breast alone or the breast and the regional nodes. If they're getting a mastectomy, then they either don't get post-mastectomy radiation or they do get post-mastectomy radiation, which is a little bit harder of a randomization. It used to just be for N1 patients. Now we're allowing micrometastases as well, and not just macrometastases. We are allowing oncotype up to 25 and age to be down to 35. And we expanded a little bit of time between the other treatments and radiation commencement to try to make it easier to enroll in this trial. So if you have this trial available, I strongly encourage you to talk to patients about this, because if there's any group within whom we might be able to safely avoid radiation treatment, it would be these types of patients. But again, what we really need is evidence that this is safe, not simply just saying, oh, that's great, let's try to avoid it. The other study that has looked at de-escalation of regional nodal irradiation is the NSABP B51 RTOG 1304 trial, which took patients who had known lymph node positive disease and randomized them to receiving regional nodal irradiation or not if they had a pathologic complete response to those upfront known positive pathologic axillary lymph nodes. And you can see here the results, thankfully shared by Terry Mamanis with me and with permission here with you today, that really showed no differences in the primary endpoint, invasive breast cancer recurrence-free interval, nor in a number of secondary endpoints, including isolated local regional recurrence-free interval, overall survival, And so the conclusions of the authors in presentation at San Antonio were that in patients who present with clinically node positive disease and convert to pathologically node negative disease after neoadjuvant chemotherapy, regional nodal irradiation did not improve 5-year outcomes, suggesting that downstaging the involved axillary lymph nodes with neoadjuvant chemotherapy can help us to optimize adjuvant radiotherapy use. And of course, follow-up for long-term outcomes continues because again, I will emphasize to you that the benefits of regional nodal irradiation may be delayed. And so more to come on that. I want to switch gears and talk to you a little bit about partial breast irradiation because there was a landmark update to the ASTRO partial breast irradiation guidelines. And there were 4 key questions that I'm going to whip through super fast simply to call your attention to the fact that this guideline exists and you can read it in detail because this guideline has not only a key question asking about where are there indications where partial breast irradiation is a reasonable alternative to whole breast irradiation. This is not a guideline saying don't use whole breast irradiation, but simply where can we safely offer patients the option of partial breast irradiation, which some of them might choose. But this is a guideline that also includes a lot of information of interest to radiation oncologists in particular about what the appropriate techniques are, what the appropriate dose fractionation regimens are, really nice guidance regarding target volumes and planning parameters and techniques, particularly with respect to toxicity and cosmesis, because as you may recall, one of the big concerns about partial breast irradiation has been that there have been some studies, including the very large RAPID study from Canada, that suggested that there were decrements in toxicity and cosmetic outcomes in the long term that, of course, are very meaningful to patients. So here are the trials that were used to inform key question 1, which was looking at disease control. With partial breast irradiation versus whole breast irradiation. And these are the randomized trials. And as you can see in most of these trials, the absolute difference in local recurrence was about 1%. And in most of these, it was not statistically significant. The different studies were designed differently with different hypotheses. So some of them failed to meet their primary endpoint. But in the end, what matters to patients is, of course, what is the expected benefit of one approach versus the other. And, in this case, there doesn't appear to be much difference, although there might be a slight difference here that you can see in terms of that 1% difference with a slightly higher local recurrence with partial breast irradiation than whole breast irradiation in some of these studies, right? So when you look at the key question 1 indications, I will refer you to the guideline, but just emphasize that the group where the committee felt comfortable recommending partial breast irradiation as a clearly should offer this option to patients are patients with lower intermediate grade disease, ER positive, greater than or equal to 40 years of age, and tumor size less than or equal to 2 centimeters. Anything else, and it became conditionally recommended or actually conditionally not recommended for things like HER2 positive tumors that don't receive targeted therapy, LVI, or lobular histology, which is very underrepresented in these trials. And it is absolutely not recommended in patients who have positive lymph nodes, positive margins, germline mutations, and extremely young age. There were also a criteria applied to patients with DCIS. So it is now the prior guideline, you may recall, was not enthusiastic about partial breast irradiation for pure DCIS, but now it may be offered to patients with DCIS who meet certain selection criteria. But not so clearly to others and certainly not for others. And so this is the nice visual depiction. And what I'll emphasize here is no matter what you have, you can end up at whole breast irradiation, but only some patients can end up at partial breast irradiation, right? That's what this diagram is taking apart. So there's some patients where the committee felt that it was quite reasonable to offer partial breast irradiation. There were other patients in whom it was reasonable to consider it, to offer it, but with some caveats. And then there were other patients where really patients should be directed to receive whole breast irradiation. And I want to thank Janice Lyons for sharing these slides. You can see her acknowledgement down at the bottom here. Key question two was focusing on techniques, really focusing on typical techniques of external beam radiation treatment, three-dimensional conformal and internal intensity modulated radiation therapy, or brachytherapy, really not recommending forms of intraoperative radiation therapy outside of the context of a clinical trial or registry. Key question three looked at dose fractionation, target volumes, planning parameters, and endorsed two dose fractionation schemas. One is the one that was used in the Florence APBI trial, which is 30 gray in 5 fractions, non-consecutive days in 2 weeks. And the other is the import low fractionation from the UK, 40 gray and 15 once daily fractions over 3 weeks. Or for patients with brachytherapy, then these regimens are recommended. But the twice daily external beam regimen that was used in the North American trials is conspicuously absent from these recommendations. So again, you can see here these dose fractionation regimens and a nice description of target volumes that can really help to guide practice, really nice planning parameters, again, available in this guideline for guidance of how to ensure that treatment is appropriately given in this setting, and nice planning parameters also for multi-catheter brachytherapy and single entry catheter brachytherapy. Again, they focused specifically on toxicity and cosmesis, and that's why the twice daily external beam partial breast irradiation to 38.5 gray was not recommended. It was based on the poor cosmetic outcomes that were observed and documented in the RAPID study and others. And so in terms of future directions, Fast Forward, of course, as you know, is a trial that uses ultra hypofractionated whole breast irradiation with 26 gray in 5 fractions. 27 gray was too much to the whole breast. And so we have to be careful about meeting these dose constraints, because if we're doing 30 gray in 5 fractions, and we know that 27 in 5 was not acceptable to the whole breast, you have to really be careful about not treating too much of the whole breast. And so this is a delicate dance. It's important to know that Fast Forward did allow for boost radiation for high risk features. So if you're de-escalating to 26 in 5 to permit partial breast irradiation, you probably shouldn't be doing that in patients who would be considered for a boost. And of course, there's further study that's necessary there. It's also important to note that all the randomized trials here required surgical axillary evaluation. And as you heard in the prior talk, with the SSO's Choosing Wisely initiative and the recent publication of the SOUND trial, surgical axillary evaluation, especially in patients like these where we're considering APBI, will become less common. And since it's possible there is a therapeutic effect on the axilla with whole breast irradiation, there's really no way for us to avoid much of axillary level 1. So it is important to recognize that in patients who have not had axillary surgical evaluation, we need further evidence. Finally, I'm going to touch upon a few studies that looked at the selective omission of radiation treatment altogether, because of course we've made many, many advances in terms of reducing the toxicity and burden of radiation treatment. I talked about 5 fractions of radiation treatment. The toxicity is quite low. But we always have to think about, the fact that there's nothing better than no toxicity and no burden if we can get disease control to be at a level that is satisfactory to patients. And so there have been many randomized trials that have demonstrated the benefit of radiation treatment after breast conserving surgery in improving local control. And the EBCTCG meta-analysis, and that's what this figure on the right-hand side is from, suggested also a modest survival benefit. But that survival benefit's really restricted to the patients who get a larger absolute reduction in the 10-year risk of any first recurrence. Not all subgroups are attaining the same absolute benefit from radiation therapy. And so perhaps in the patients who have smaller absolute reductions in their risk of first recurrence, it might be reasonable to consider omission of radiation treatment in certain patients who think about their own values and preferences and reflect on this and decide that that might be the best approach for them. So there have been a number of landmark trials that have sought to define this elusive, holy grail population of women who have reasonable local control in the absence of radiation treatment, that they might say, I don't even want 5 days of radiation at this point. I'm good. Let's call it quits with surgery and endocrine therapy. So CALGB 9343 was the first study really to come out in the literature where it came out in 2004 with its 5-year results and showed that the risk at 5 years of local recurrence was 4% with breast conserving surgery and tamoxifen alone, no radiation, and 1% with radiation treatment added to breast conserving surgery and tamoxifen. So there was a statistically significant p less than 0.001 benefit of radiation treatment, but it was very small in absolute magnitude. Meanwhile, in the same, and this was women who were 70 years of age and older with clinical stage 1 disease, who had hormone receptor positive disease. And so this is the first study that reached the literature where we said, maybe at least for women with like a shorter life expectancy where these 5-year data are meaningful, this might be something reasonable to offer. Omission of radiation treatment. In the same issue of the New England Journal, a Canadian trial was published in women who were 50 and older. And even in the planned subgroup analysis of highly favorable patients, T1N0 disease that was estrogen receptor positive, the 8-year risk of recurrence was already 15%. So in these younger patients, it was felt to be younger postmenopausal patients, it was felt to be still not an appropriate option, but in older postmenopausal patients, particularly with the amount of follow-up on this trial at that time, it was felt to be something reasonable. And then we got longer follow-up, right? And the longer follow-up showed that these curves continue to diverge, right? These recurrences continue to accumulate. But at 10 years, the risk was 10% of local recurrence in the patients who didn't get radiation and 2% in those who did. And there are some women who are 70 and older who say 90% is good enough. I'll take the 10% risk. And there are many women who will say, you know, you can give me an 8% absolute risk reduction with radiation, and you're telling me it's how many treatment fractions and what are the risks? And you know what, thanks, I might actually take it, right? Prime 2 came out just this year, very similar to CALGB 9343, but including women 65 and older, almost identical results. Very, very reassuring, right? The same exact results. 4%, 1% is what I said that CALGB had. You see this? 5%, 1%. 10% and 2% is what CALGB did. See that? 10% and 1%. So very, very consistent results. Again, there are many women who want that benefit in terms of local recurrence reduction, even if it doesn't come with a survival advantage, you know, as I talked about at the outset. But we still want to offer patients choices. That's what's meaningful. And so the Canadians, to their credit, went back and looked at whether there were subsets of patients on their trial of women 50 and older who might be able to safely consider omission of radiation treatment. And they really focused in on a low-risk clinical luminal A group who were 60 and older and had immunohistochemical features that suggested a low biological risk. And you can see here the results of the Lumina trial that were published just this year that suggested that at 5 years, and they truncated the follow-up at 5 years, so we do not know what happened after 5 years in Lumina, but out to 5 years, the risk is really quite low. The median age ended up being 67 on Lumina, so it still doesn't really tell us much about the patients who are the younger postmenopausal patients. And so we continue to have an interest in this. Are there other ways we might select patients? We know that genomic assays have been used to select patients for treatment with systemic therapy. And indeed, there is evidence that suggests that these scores that are already being obtained in routine practice to make systemic therapy decisions might help to discriminate the local regional recurrence risk, and perhaps even better in unirradiated patients. You'll remember that in NSABP trials that were summarized in this study, that the mastectomy patients in that era did not receive radiation. And you can see that it really does seem to have some utility in these unirradiated patients. And so that is what motivated us to launch in 2015 the IDEA trial. This is a study that I led with the collaborators at 13 other sites. These were women 50 to 69 years old in order to get at this question of what about the younger postmenopausal patients? And they had lumpectomy surgery with negative margins, 2 or more millimeters, ERPR positive disease, HER2 negative, node negative disease, pathologically assessed, and oncotype DX21 gene recurrence score less than or equal to 18. And they were consented on a single arm study of omission of radiation treatment, very similar to Lumina, but using a genomic assay rather than using IHC and centralized Ki-67 assessment. Here we were using the score that people already came into our clinics with. Think about how cost effective that would be if we could just look at that, and that would help us identify the risk of a population. And what we consented them to do was proceed with 5 years of standard endocrine therapy, at least 5 years of endocrine therapy per treatment guidelines, and 10 years of surveillance on study. And our primary analysis was to be conducted after 5 years after the last patient enrolled. So we presented those results at San Antonio. The mean age of the patients was 62. So, finally getting at, the mean age of breast cancer diagnosis in the population is 62, finally getting at these younger postmenopausal patients. And what we found was very heartening at 5 years, overall breast cancer specific survival of 100%, freedom from recurrence of 99%. In other words, 2 patients recurred before 5 years. One of those was an isolated ipsilateral axillary recurrence, and one was an ipsilateral breast event. But we're going to tell you what happened after 5 years. It's important to take this with a grain of salt. We don't have lots of follow-up beyond 5 years, but we do already have 6 additional patients who have recurred later than 5 years. Now, none of these are distant recurrences. This is a population where they were highly compliant with endocrine therapy, okay? Including many of the patients who recurred were compliant with that 5 years of endocrine therapy. And it does cause us to question what happens if we give 5 years of endocrine therapy once the endocrine therapy ends. Now, of course, those of you who remember your biostats from medical school, once your numbers down here get really small, you can't make anything of your Kaplan-Meier curves, right? So be very careful with actuarial risk estimates beyond 5 years. We can't say anything about these numbers, but what we can say is that the crude risks of recurrence remain low at this point, and long-term follow-up of this and other trials is going to be absolutely essential. So IDEA showed a very low 5-year risk. People got really excited about this at San Antonio, and I kept having to say, I love that this is in the press program, and I love that you think this is important work, but please recognize that this is not a sign that you should go and start offering younger postmenopausal women omission of radiation treatment off trial right now. What we need is long-term follow-up and accrual to ongoing trials. It's important, though, to do these trials to empower patients with choices and return to them the sense of agency that can be deeply meaningful in the context of a recent cancer diagnosis, as we all know. Really important cautionary notes: don't generalize to patients with less extensive surgery. We required 2 mm margins. Be careful. We required pathologic nodal evaluation. Be careful if compliance with endocrine therapy is not expected. And again, as I've been emphasizing throughout this talk, really reflect on the fact that even since we started IDEA in 2015, there have been advances in radiation treatment that make the decision really a close call. And let's not have headlines or comments to patients that talk about the brutal effects of radiation or how wonderful it is that Dr. Jagsy and colleagues are doing work to reduce harsh radiation. Dr. Jagsy will tell you that radiation is not harsh and it's not terrifying. It is something that I want patients to have a choice about. And there are some patients who can apply their own values and preferences and will have a low enough risk that they should get a choice. Many of them will choose radiation when they hear about radiation. And it is our duty to be very responsible interpretation, because otherwise we also end up with a situation where patients who clearly do get a big absolute benefit from radiation treatment are terrified of it. So what we need to do is enroll to ongoing trials. NRG-BR007, the DEBRA trial, is randomizing women almost identical to the patients that IDEA included and served as preliminary data for to radiation treatment or observation after breast conserving surgery. And it's an incredibly important study to do, because not only does it add to the numbers that we will have to evaluate this question, but with the randomization, it allows us to look at the impact of these decisions on quality of life, whether worry about recurrence, whether endocrine therapy side effects, because people end up persisting with endocrine therapy potentially more if they haven't gotten radiation and they feel more dependent on it, whether those differ by treatment approach, because those are things that will be meaningful to patients as well. So In conclusion, 2023 really was a banner year for advances in personalizing radiation therapy. In terms of regional nodal irradiation, we saw a meta-analysis revealing that regional nodal irradiation has benefits that don't appear immediately and appear to exist regardless of subtype. The absolute benefits depend on the absolute underlying risk of recurrence, and ongoing research to identify some patients who are expected to have a clinically insignificant benefit and to reduce RT-related toxicity, which of course helps to increase the net benefit on composite endpoints, remains essential. Look forward to the full publication of the B51 trial that looks at whether we can use pathologic complete response to guide us and its long-term follow-up, which is again incredibly important. We also learned about the synthesis of a lot of data about partial breast irradiation in the form of a treatment guideline that has reviewed the numerous trials that established options to reduce the toxicity and burden of radiation treatment and increase the number of options that are available to our patients. Lots of good stuff in there about dose, fractionation, volumes, treatment planning. And finally, studies that are ongoing about omission of radiation treatment. We already offer the option of omission of radiation treatment to women who are 65 or 70 years of age and older who meet the entry criteria of, sort of stage 1 hormone receptor positive, based on prime 2 strongly positive disease. But it's important to recognize that we offer that with the note that both of those trials were positive trials showing that there was a benefit from radiation treatment, about an 8 or 9% absolute benefit in terms of radiation treatment. Some patients say that is absolutely something that they're happy to forego, and others choose otherwise. And so we need these ongoing trials that are seeking to better define risks and benefits so we can all offer treatment options to patients. I will just throw in there that we should also be doing studies in the United States like they are in Europe. Europa is actually randomizing patients to receiving radiation treatment versus receiving endocrine therapy, because I will tell you the single most common question I get, and I bet many of you get, is in a patient who's 75 years old and meets the ALGB criteria, and I tell her about all of the data about omitting radiation treatment. She will often say to me, okay, but what I really want you to talk to me about is whether I have to take the 5 years of endocrine therapy. I actually would be perfectly fine with your 5 days of radiation treatment. I'm not so sure about the 5 years of endocrine therapy. And we need evidence in this space. We do have some, but we need more. And we really do need to be joining our European colleagues in doing those kinds of studies. Really, in a hopeful conclusion, we've really never been better positioned to deliver meaningful treatment safely to patients and to provide them with choices for their treatment options. So with that, I will open up to any questions.
Thank you so much, Dr. Jackson. Is there anyone who has a question?
Do you expect B51 to be practice changing now? Do you think it needs more follow-up? How do you see that playing out in clinical practice in 2024?
It's the million-dollar question, right? I think that it has given us great unease. There was a glorious month between the publication of the EBCTCG meta-analysis and the results of the B51, where we felt like we finally were starting to get clarity. And I think that there's radiation oncologists will often send emails to one another asking what to do with difficult cases. There has been a flurry of every expert in the country emailing every other expert in the country saying, so would you apply B51 to this case or not? And I don't think we really know. What I would say is that we have to share this information with our patients and make sure that they understand the follow-up on the studies, the design of the studies, and ultimately apply their own values and preferences. We are at a point where the risk of regional nodal radiation, especially for patients who are going to get breast radiation anyway, adding on those regional nodal radiation fields, if we can minimize doses, tends to be pretty safe and well tolerated. So I think having those individualized conversations about what we expect for this individual patient is incredibly important. And what I would ask is that for anyone who's in this audience who is a surgeon or a medical oncologist, please send these patients to your radiation oncology colleagues. I will throw out there that there's no financial incentive for us to treat with regional nodal irradiation in a patient who doesn't need it. It's actually more work for us and we bill the same. So let us have the conversation with the patient. Let us do the right thing for the patient. I really do think that these are very nuanced conversations that take a long a long discussion.
All right, do we have any other questions? All right, any questions from our virtual attendees?
All right, well, seeing no questions, Dr. Jackson, thank you so much for that presentation and for sharing your time and expertise with us. We really do appreciate it.
It was my pleasure. Thank you so much.